Hello everybody, and welcome to PathoLogic. Today we're going to be discussing anemia. This is actually a suggestion from a viewer, so as a reminder, if you have a video suggestion, drop them in the comments and I will do my best to get to those topics. Anemia refers to either a decreased hematocrit or decreased hemoglobin. There are three major causes, which I think of as the three H's, so they are hemorrhage, hemolysis, and hematopoietic. Before we look closer at those causes, we should look at how we characterize anemias. When evaluating an anemia, we want to assess three main factors: the severity, the red blood cell indices, and regeneration. These factors give us clues about the underlying cause of the anemia and help us rule out some of our differentials. We'll start by taking a look at the red blood cell indices. The first feature that we'll look at is the mean corpuscular volume. This refers to the average volume of the red blood cells. We define this as either macrocytic or too large, normocytic or normal-sized, or microcytic or too small. Macrocytosis refers to RBCs that are too large. The most significant cause of macrocytosis is the release of immature red blood cells. As RBCs mature, they become smaller and smaller, so if they are released from the bone marrow too soon, the circulating RBCs are going to be larger than we would expect. Other potential causes include abnormal RBC development, abnormal membrane composition, and cell swelling. Microcytosis refers to RBCs that are too small, and this usually develops due to an iron deficiency. However, we can also see it with other conditions that affect hemoglobin production. The next characteristic is mean corpuscular hemoglobin concentration, or MCHC. This is the content of hemoglobin per unit volume of red blood cell. We define this as either hyperchromic, having too much hemoglobin, normochromic, having a normal amount of hemoglobin, or hypochromic, having too little hemoglobin. Hyperchromasia is always an artifact, as RBCs cannot contain more hemoglobin than normal. We see this when there is reading interference by things like lipemia, Heinz bodies, hemolysis, or nucleated RBCs. On the other hand, hypochromasia is always pathology. It results from too little hemoglobin in the RBCs, usually due to either release of immature red blood cells or from iron deficiency. We can also see it with other conditions affecting hemoglobin production, such as some nutritional deficiencies. Next, we have to determine whether or not the anemia is regenerative. Regeneration refers to whether the bone marrow is responding to red blood cell loss. We primarily assess this by counting reticulocytes, or immature red blood cells, in the bloodstream. These reticulocytes appear as aggregate or punctate cells on a new methylene blue stain. We can also see them as polychromatophils in our typical in-clinic stains, like a Diff-Quick stain. There is one exception to looking for reticulocytes. In horses, we actually assess macrocytosis. Macrocytes are more reliably released from the bone marrow than reticulocytes during regeneration in this particular species. Other signs of regeneration that you may see in any species on a blood smear include basophilic stippling, nucleated red blood cells, and Howell-Jolly bodies. A regenerative anemia is an anemia where there is adequate hematopoiesis by the bone marrow relative to the degree of anemia. Whether or not the regeneration is adequate depends on the severity and chronicity of the anemia. Usually, assessing adequacy requires individual patient interpretation. Also remember that it usually takes 3 to 5 days for the bone marrow to activate. Therefore, you may see a non-regenerative anemia if you analyze blood too quickly after the inciting event. A true non-regenerative anemia suggests that there is bone marrow suppression that is preventing hematopoiesis. With that background, we can now look at the common causes of anemia. Hemorrhage is the first H on our list. Massive blood loss results in the loss of red blood cells, and this can be either internal or inside the body, or external with blood releasing out into the environment. Interestingly, internal hemorrhage can actually result in autotransfusion, where red blood cells are absorbed relatively intact, minimizing the degree of anemia in this type of hemorrhage compared to external loss. In most cases, hemorrhagic anemia is regenerative, as the bone marrow attempts to replace those lost red blood cells. Common findings with hemorrhagic anemia include a low hematocrit due to red blood cell loss, and low total protein due to the loss of protein within the lost blood during hemorrhage. As mentioned, these anemias are typically regenerative, so you will have an elevated reticulocyte count. Most cases are normocytic and normochromic in cases of acute hemorrhage. However, you may see changes in these values if the hemorrhage is chronic. Our next H is hemolysis. This refers to destruction of red blood cells. Hemolysis can either be extravascular or intravascular. Extravascular refers to phagocytosis by macrophages in the spleen, liver, and bone marrow. Intravascular refers to rupture of red blood cells within the vessels. Most cases of hemolysis are regenerative. On blood work, you will typically see a low hematocrit due to the red blood cell destruction. Often you will see an elevated total bilirubin due to release of bilirubin from those damaged red blood cells. You will also see an elevated reticulocyte count indicating regeneration. Finally, you may see macrocytosis and hypochromasia. These changes occur due to the release of immature red blood cells, which are bigger and have less hemoglobin than their mature counterparts. Extravascular hemolysis is always present in animals that have hemolysis. As mentioned, this type of hemolysis occurs through erythrophagia by phagocytes in the spleen, liver, and bone marrow. This phagocytosis is usually triggered by some sort of immune response against the RBCs. This can either be due to an autoimmune disease, or because the RBCs are abnormal and the immune system flags them for removal. On the other hand, intravascular hemolysis may or may not be present. We see intravascular hemolysis when there is rupture of red blood cells within circulation. Typically, this type of hemolysis is associated with either an immune response or oxidative damage to the red blood cells. Now we can look at some specific causes of hemolysis. The first is immune-mediated hemolytic anemia, where there is immune activation against the red cell membranes. This results in primarily extravascular hemolysis. One of the key findings of IMHA are spherocytes, which are red blood cells that have lost their normal biconcave disc shape. In this condition, essentially the macrophages take a bite out of the cell, causing it to reform into a ball instead of the typical disc shape. Erythroparasites are parasitic organisms that live within red blood cells and include species like Mycoplasma, Anaplasma, and Babesia. These infections typically result in extravascular hemolysis, although some infections may also have an intravascular component. The main finding of these disorders is visualizing the organisms within the red blood cells when you're looking at a blood smear. Next, we have oxidative injury. Oxidative damage injures the red blood cell membranes, causing them to form unusual shapes. Common causes of oxidative damage include acetaminophen toxicosis in cats, red maple toxicosis in horses, and copper toxicosis in numerous species. These conditions result in extravascular and intravascular hemolysis, as the cell membrane damage may result in cell rupture within the vascular system, and additionally, the abnormal shapes may be flagged by the immune system for removal within the spleen, liver, and bone marrow. Common findings include Heinz bodies, which look like little noses on the red blood cells, and ghost cells, which look like empty or non-staining red blood cells. These are both indicators of membrane damage. Fragmentation anemia results when red blood cells travel through damaged vessels or through clotted areas. Traveling through these areas causes shear stress, resulting in damage to the red blood cells. Example conditions associated with fragmentation anemia include things like hemangiosarcoma and disseminated intravascular coagulation. These changes result in both extravascular and intravascular hemolysis. Common findings include keratocytes, which have a little bubble in the membrane, schistocytes, which have an irregular or oblong shape, and acanthocytes, which have rounded projections all along the membrane. Finally, we get to our last H, which is hematopoietic. This refers to decreased production by the bone marrow. There are many potential causes. The main one that we see is suppression of the bone marrow, usually from things like drugs or stress. We can also see decreased bone marrow production from things like nutrient deficiencies or destruction of hematopoietic cells by things like tumors. These anemias are typically non-regenerative since the bone marrow itself is affected. Common findings for this type of anemia include a low hematocrit and a low reticulocyte count, as these anemias are not typically regenerative. The MCV and MCHC can vary with these conditions depending on the underlying cause. We will start with iron deficiency anemia. This condition results from an absolute or functional depletion in iron stores. For example, this could result from reduced dietary iron intake or iron loss, or it could result from a functional deficiency due to something like abnormal iron metabolism by the liver. Iron deficiency anemia causes a microcytic hypochromic anemia due to reduced hemoglobin production. Bone marrow suppressing drugs can either suppress the bone marrow's activity directly, or they can destroy erythropoietic precursors. Example drugs that have this effect include chemotherapeutic agents or hormones like estrogen. These anemias are typically microcytic and may be either normochromic or hypochromic. Anemia of inflammatory disease results from suppression of erythropoiesis by inflammatory cytokines. This condition is the most common cause of a mild to moderate, normocytic, normochromic, non-regenerative anemia in our veterinary species. You can often see other clues like an inflammatory leukogram, hypoalbuminemia, etc., on the animal's blood work to help indicate that this is the underlying cause of that anemia. Anemia of endocrine disease results from a generalized decrease in metabolism, which also decreases erythropoiesis. We most commonly see this in association with hypothyroidism and hypoadrenocorticism. This results in a mild to moderate, normocytic, normochromic, non-regenerative anemia. Anemia of renal disease is similar, but it results from decreased production of erythropoietin by the kidneys. Again, it causes a mild to moderate, normocytic, normochromic, non-regenerative anemia. You may see echinocytes in some cases, as these cells can be associated with glomerulonephritis. To finish off, we will look at some interpretation examples. Here's our first example. To start, we can see that there is a high reticulocyte count, which indicates that there is a regenerative anemia. We can also see that it is normochromic and normocytic. A regenerative, normochromic, normocytic anemia is typically associated with hemorrhage or hemolysis. In this case, we also have a low total protein. This typically suggests that there is blood loss occurring, so we would suspect a hemorrhagic anemia in this case. For the next case, we have the same assessment of a normocytic, normochromic, regenerative anemia. However, now we have a high total bilirubin as well as ghost cells. High total bilirubin is indicative of hemolysis, where there is release of bilirubin from the damaged cells. Ghost cells are a common finding in intravascular hemolysis. In particular, ghost cells are associated with oxidative injury. Potential causes of oxidative injury could include acetaminophen toxicosis, red maple toxicosis, or copper toxicosis. This case has a normocytic, normochromic, but non-regenerative anemia. Usually we see non-regenerative anemias due to either bone marrow destruction or extramedullary disease. This particular case has an inflammatory leukogram. This suggests that we may be seeing suppression of erythropoiesis due to inflammation, otherwise known as an anemia of inflammatory disease. This case has a microcytic, hypochromic, non-regenerative anemia. This is the classic finding of iron deficiency anemia. This occurs because hemoglobin production requires iron, and without iron, the cells are going to be small and pale due to the lack of proper hemoglobin formation. Our final case has similar findings to the last one. Again, these are clinical findings of iron deficiency anemia. However, low total protein gives us another clue that we can use. Remember that low total protein is associated with hemorrhage. Chronic hemorrhage can result in iron deficiency due to that iron being lost in the hemorrhage. So in this case, we actually have two factors contributing to this anemia, both hemorrhage and iron deficiency. To summarize, you want to start by looking at whether or not the anemia is regenerative or non-regenerative. Look for things like reticulocyte counts or macrocytosis. Then assess red blood cell indices like MCV and MCHC. Identify any other clues that are available to help you understand potential underlying pathogeneses like abnormal red blood cell shapes or other blood work changes. Finally, put it all together and see if it actually makes sense. Thank you for watching PathoLogic. If you enjoyed this video, remember to like, subscribe, and to share with your classmates. If you're feeling generous, there is also a link in the description where you can buy me a coffee to help fuel future video making. Thanks again for watching, and we will see you in the next video.